Welcome, dear friends, to today's session of Young India Intensivist webinar. The topic for today is acute kidney injury. And today it will be presented by Dr. Rajasekara Chakravarthi sir. And I don't think there's anybody in our country better than him to speak on this. So we are indeed honored that he is there on our platform today. And sir has actually just returned from the US today morning after attending an international conference on AKI and CRT. So just a brief introduction to Dr. Chakravarthi sir. He is a member of the KIDCO on AKIs 208 and 2019. He's a member of AKI and ADQI. He's a member of the AKI Committee of International Society of Nephrology, and a committee member of International CRT Conference, which is held every year in California since the year 2005. He is a reviewer of the committee for Indian Journal of Nephrology, Indian Society of Nephrology, Indian Heart Journal, and so on and so forth. And he's been an active organizer of AKI conferences in our country for international and national forums. So with that brief introduction, I will now like to introduce Dr. Kothari sir. Dr. Kothari sir, thank you very much for joining us. Sir is
Thank you for inviting me.
And head of Department of Critical Care at Kokilaben Hospital and Research Center, Mumbai. He's also a consulting physician. So over to you, Kothari sir, to introduce the topic, and then we can start from the presentation.
Thank you so much. So I think acute kidney injury is a very important topic that needs to be understood, because the kidney is a very integral part of any kind of homeostatic mechanism that is set into place, especially in individuals who undergo any critical illness. And the kidney having these very important functions of metabolic regulation, taking care of the acid-base balance, taking care of the fluid balance of the body. It is very important to understand the pathophysiologic processes that give rise to acute kidney injury, so that in a patient who's presenting with acute renal dysfunction, it is important to know what underlies the causes and how to approach it in a manner that will best befit the patient. Also, it's very important to understand that what are the main indications for dialysis, because this is a topic that I am sure that Dr. Rajasekara will be briefly touching upon. But what we need to understand out here is that this is a very vital organ that has a very interesting physiology. And if we approach it in a pathophysiologic manner, it makes a lot of sense in order to not only understand it, but also at the same time treat it.
Thank you, sir. So over to you, Dr. Chakravarthi sir, to start the session, sir.
Thank you for the kind words, Dr. Tapesh and Dr. Kothari. So for all of us, when every day we go into the ICU, there are patients with a particular disease like sepsis, who may have kidney disease, who may not have kidney disease. So presently, we are fully aware now, all over the world, the data that is clearly telling us, whenever there is a renal involvement, the outcomes are very poor. Compared to the same cohort of patients, when kidney involvement is not there, the outcomes are better. The second thing is, not only the acute kidney injury, the stage of acute kidney injury is what dictates the outcomes. So in other words, irrespective of the reason for which the patient has come to the hospital, the outcomes depend on not the primary reason alone, but the amount of or the stage of kidney disease that is there in the particular patient. So let me give and start the discussion, which is relevant to all of us today, with a case scenario. This gentleman, 44-year-old male.
Sir, you have to go full screen.
Yeah, 44-year-old male was actually a politician and son of another politician. So he had his yearly checkup where we knew his glomerular filtration rate estimated was around 90 ml per minute. There was no protein loss. 6 months later, he came to the emergency room with multiple stab injuries and a gunshot wound. He was in shock, pulse and blood pressures not recordable. He was on multiple inotropes and then had to be started because of anuria on CVVH-DF. 14 days of CVVH, subsequently was switched to SLED, discharged 33 days after admission, discharged creatinine 1.7 milligrams, whereas his baseline was normal, around 0.8 or so. Protein loss was more than 3 grams. So this particular case scenario clearly tells us a person who had a normal renal functions, no protein loss to start with one episode of severe AKI can have established chronic kidney disease with not only creatinine going up, but protein loss being more than 3 grams. So today, if you look at our understanding of kidney disease in the ICU, let me start a little more detail about the chronic kidney disease. If you look at the SEEK study data, which was a very good study conducted across the country, it put the CKD prevalence in our society at around 17% or so. We conducted between 2015 and 2020 almost 10,000 screenings in urban Hyderabad and found that when you go to urban slums and start looking at prevalence of CKD, it comes to close to 14.7% or so. So if you classify this chronic kidney disease, which is a huge burden for the country, into various causes, diabetic nephropathy scores the highest, followed by chronic interstitial and chronic glomerulonephritis. Now, this is what I would have told you 10 years ago. But today, we know for sure, apart from these causes, the acute kidney injury, which you and me come across in the hospital, in the ICU, also leads to some amount of chronic kidney disease. And in several communities in the world, there is a clear understanding 30% of CKD actually comes from acute kidney injury. So let us try to understand why this particular entity of AKI not only causes very poor outcomes for patients when they get admitted to ICU, but downstream, after 6 months, 1 year, 2 years, also a single episode of AKI determines the outcomes. So the present understanding, whatever data that we know, acute kidney injury has short-term and long-term outcomes. And in that, you may have a significant chronic kidney disease wherein patient gets discharged, but subsequently continues to have renal dysfunction, which progresses over a period of time, including taking them to dialysis stage in the next couple of years. So this particular cartoon from International Society of Nephrology, if you see, there is an insult, which is the acute kidney injury, after which very rarely you have a small cohort of patients who can have a full recovery. Majority go into a stage of chronic kidney disease, and some of them reach ESRD and dialysis stage very early. Some take next few months to few years. We also know today now, insult, there is a damage in the kidney. There is a fibrosis which occurs inside the parenchyma as a step ladder pattern. So every insult takes the patient closer to end stage and dialysis requirement. We understand mechanisms today, how the damage occurs, inflammation occurs, repair occurs, and fibrosis also occurs. So if you look at AKI, it is a spectrum of AKI leading to CKD, and those who have CKD have a more risk of developing AKI when they are in the community and come back to hospital again and again with recurrent AKI. So the term recurrent AKI is now thought to be a very common thing Somebody develops a AKI, they enter into some form of CKD, they have next insult, and then they go on like this, needing dialysis. Not only that, there are other changes in the body, including cardiovascular disease, incidence of anemia, incidence of new onset sepsis. At the end of 2 years after a single episode of AKI, these patients come back to hospital more often and they also die more often. So what do we know today about why this AKI means such bad outcomes? So if you look at the normal tissue and the injured tissue, you can see in the vessels, there is fibrocytes, myofibroblast, and inflammation with lymphocytes and macrophages. So when the repair does not occur properly or normally, there is an element of fibrosis, and these kidney has islands of fibrosis, and the adjacent area also becomes ischemic, and this ischemia fibrosis progresses to CKD in these people. So we are broadly now classifying these mechanisms into three. The first one is nephron loss. You have an injury, you have some nephron loss. Second one is inflammation as part of AKI. Even a simple ATN or acute tubular necrosis has inflammation. This inflammation recovers by fibrosis, and as I told you, there are islands of fibrosis in the parenchyma which cause ischemia to the adjacent tissue. This is known as vascular rarefication, leading to hypoxia and tissue injury and progression of chronic kidney disease. So the duration of AKI, severity of AKI, that means stage of AKI, both have a bearing on the residual damage, thereby causing CKD. The other factors which we now know are associated with poor outcomes apart from duration and severity of AKI are baseline renal function. As I told you, those who have a CKD, they are more prone for AKI. Serum albumin levels during the course of the hospitalization and the severity like dialysis requirement also. So we now clearly know, with that background, we can go on to the other discussion. Short-term outcomes, we are talking of inpatient mortality, number of days in the ICU, whereas long-term outcomes, we are talking of CKD progressing to end stage, needing dialysis, cardiovascular disease, increased risk of mortality, even 2 years after one episode of AKI. So the present ICU patient is somebody like this. This gentleman actually had toxic fume inhalation in his factory, came to us walking, had a lung injury, then developed sepsis, had a cardiac arrest, went on CRRT, ECMO, and you can see there is a filter of polymyxin for sepsis. So you and I are capable of now taking care of such complex patients, but whatever you do, how early you do, and what filters you use actually determines the outcomes in the form of chronicity ensuing in these people. There is some data to talk about the modality of dialysis, like peritoneal dialysis could be better for recovery of AKI compared to hemo, but many times we are not able to choose the modality for various constraints. Could be the constraints which are indigenous to the particular setup, training, cost, all those things you have to take into consideration. I will not have time to go into the data of modality, so I just thought I'll show you. This is one of our patients post CABG on peritoneal dialysis by cycler. So we never dialyze this patient except with PD. So acute PD is something that you and I should be familiar with, because in our country, it makes a lot of sense to keep some patients on PD and bring them out without taking them onto hemodialysis. So with that background, if you look at what we are doing as far as diagnosis is concerned, this is a conceptual model of AKI from Akute and ADQI. You are looking at the kidney which is normal, enters a phase of increased risk, and then develops damage, drops the GFR, and creatinine goes up. So you and me today are able to look at patients after they have dropped their GFR. Till then, we don't know that this particular patient is going to develop kidney disease. Whereas, if you want to improve the outcomes of AKI, from all the list that we just discussed, both short-term and long-term, we have to move towards the left. Look at kidneys or patients who are at increased risk and try to avoid developing AKI. As you are all aware, we have these AKI bundles now. So how do we get there is a question. And can we improve on early diagnosis and also interventions in such a way that we don't allow the kidney disease to develop to a severity needing dialysis in the ICU. So present, the reason why we are not picking up earlier is we are using two markers. One is serum creatinine, the other one is estimated GFR. Estimated GFR also uses serum creatinine. And as you can see from this cartoon, if you have 140 ml per minute of GFR, for it to drop to 70 ml, that means 50% drop, your serum creatinine will go from 1 to 2. So 1 mg rise in the serum creatinine will drop 70 ml of GFR. So that is something that you need to keep in mind, even in acute situations. From 70 to 35, another half drop, your creatinine will double from 2 to 4. So by the time the patient has gone to 4, the GFR is only 30 ml. And from 35 to 17.5, another half in the GFR, creatinine goes from 4 to 8. So what you notice here is, in the early stages, small changes in creatinine mean huge drop in GFR. So you and I will miss the diagnosis of severe AKI because patient may have just changed a delta creatinine of 0.3 milligrams or so. So this is something that you have to constantly keep in mind in the ICU when you are seeing the patient. Not only that, there are several other factors which affect the serum creatinine. The generation rate, volume of distribution, tubular secretion affected by other medications, and the interventions that you do. Simple thing like a fluid overload causes dilution of serum creatinine. So already we know that small changes in creatinine you are not likely to pick up because the change in GFR is not apparent. At the same time, if the patient is volume overloaded, you are again going to miss a diagnosis of AKI, sometimes for several days, because you have not kept this in your mind as a possibility. So keeping that, we had a introduction to biomarkers in somewhere in 2010 or so. And for you and me, this is going to become standard of care in the next couple of years. Wherever you go in the world, there are people using multiple biomarkers. And I had the honor of being part of this particular ADQI. This was in Dublin, conducted by Patrick Murray. And we brought out four papers on how to use biomarkers. But this was quite preliminary at that point in time. Now there are many more papers talking to us exactly how to use and which markers to be used. So using these markers, you should be able to move towards damage markers and functional markers, which I will elaborate, which will help us to move to earlier diagnosis of acute kidney injury by several days. So when you use a rifle criteria or a Akin criteria or a KDIGO criteria, on one hand, that means you are using estimated GFR by the creatinine and the urine output criteria, superimpose on that biomarker positive and how high the level is, then you are in a position to come to an earlier diagnosis and probably can lead to better outcomes. And there are several studies randomized which have been done in the last couple of years. I will not be able to go into the details, starting from NGAL in cardiac surgery population, subsequently interleukin 18 from the Yale group, Dr. Chirag Parikh's group, and then the Topaz and Sapphire studies wherein they use the cell cycle arrest biomarkers, TIM2 and IGF. We now have several biomarkers in our armamentariums. So these biomarkers can be classified into markers of glomerular function, markers of inflammation and repair, and markers of tubular function, and also markers of cell stress. So once you have a AKI insult, by the time the serum creatinine goes up, we just discussed, it may take 48 to 72 hours. So the biomarker should be able to diagnose, detect acute kidney injury early, prognosticate for you and me based on the whether it is sustained elevation or not, and in future also talk of future risk of CKD, mortality, and renal reserve. So you will get a 4x4 matrix wherein you may have a cohort of patients in whom there is no elevation in the serum creatinine. There is no elevation in the biomarker. So this is a normal kidney. You may have only biomarker elevation. Creatinine is not elevated. That means there is a tubular injury, but function is still intact. So the creatinine here is a functional marker and the biomarker is a damage marker of the tubule. The third category is you have creatinine elevated, but the biomarker is not elevated. These are people in whom the function has dropped without any damage to the kidney, typically pre-renal azotemia. You don't have a damage in the kidney, parenchyma, but you have a function drop, therefore the creatinine goes up. But the worst category is where the damage marker is also elevated and the functional marker like creatinine also is elevated. This is the cohort of patients who will worsen, who will go on dialysis in future. So these 4 categories should be clearly elucidated and then look at them a little early, involve nephrologist in the treatment of these high-grade injury patients, which definitely will lead to some amount of better outcomes. So when you are looking at a damage marker, actually what is happening at the kidney level is changes in the microcirculation, vasomotor nephropathy, oxygenation depletion to the tubule cell causing ATN, and then some amount of maintenance and repair at the tubular level. We have now biomarkers for each stage of this acute kidney injury. So when you have these biochemical markers superimposed on the functional markers, there is several studies, including that I already mentioned. Apart from that, there is one Privaki study, Big Pack study in surgical patients, all of them talking of earlier use of these biomarkers, picking up AKI in the ICU close to 72 hours earlier than before. So as I just told, the examples for functional markers positivity without damage marker positivity is hypovolemia, hepatorenal syndrome, nephrotic syndrome, cardiorenal syndrome, and very early sepsis. So these are patients in whom creatinine goes up, but there is no damage marker going up. Whereas you have later part damage tubule happening and then repair and then fibrosis. So early rise in the damage marker is going to be a prognostic marker, and it will indirectly tell you what to do and what not to do for your patients. So once you have a patient in ICU, the biomarker is useful to suspect AKI. There are biomarkers which tell you that the patient or this kidney is at risk or there's a stress going on in the kidney. They are useful for diagnosis. You can categorize them into AKI or no AKI. You can also define the etiology. What is the type of AKI? And also select a particular type of treatment target based on the biomarker. So moving to management of AKI, you have a patient now you are picking up very early because you are using a biomarker. So you pick up before the injury has happened. Therefore, there is a possibility for you to prevent AKI in high-risk population when they get admitted to your hospital or ICU, and then prevent the downstream effects. If you look at dialysis, we have to categorize them into timing, access, modality, dose, anticoagulation, and also weaning from RRT when patients develop severe AKI. Each of these subtopic has a lot of data and literature which is given us newer insights how to manage and how to bring them out of dialysis requiring AKI. We may not be in a position to go through each one of them or discuss the data in detail, but I will quickly go through the concepts that we understand today as far as AKI management is concerned. So, should we start RRT or not in this group of patients? Is there a way to decide? Can you hear me? I thought internet was unstable. Yeah. Is there a way to decide how to avoid or how to decide when to start for these patients, and then what are the modalities to be considered? So the present understanding is to look at AKI patients as what is known as 5R approach: risk assessment, recognition, response, renal support, and rehabilitation. So the ADQI that we conducted in Hyderabad, the only ADQI that was in India, was the 18th ADQI. It talked of detection and management of AKI in the developing world, and we clearly addressed all the 5 R's or the 5R approach. Risk assessment, these are 6 papers which came out of these particular ones published in Kidney International. I will not be able to go through each of these paper, but quickly mentioning that all the 5 were discussed, and I will just spend a little time on the paper on renal support. So when you look at a patient in your daily rounds in the ICU, look at whether this person needs dialysis or not. Many times it's not an easy decision. Sometimes we delay so much that the outcomes are really bad. So this particular paper discusses the demand versus capacity paradigm, wherein you look at a patient as what is the demand on the patient, what is the amount of fluid you are going to give, any transfusions, and what is the capacity, that means the urine output that the patient has got. For example, somebody can have a high catabolic state but normal kidney function. You can still wait and not offer support for this patient. Whereas when the demand is high and the capacity is low, patient already has a drop in GFR, urine output is not good, it's better to get into a support, renal support earlier for this patient. Keeping this in mind will make the decision easier. And when you start looking at patients with this in your mind, what is the demand for the next 24 hours and what is the capacity of this particular kidney, it becomes much more easier for you to make a diagnosis. So what do you take into consideration for looking at the demand, the severity of illness course, or the chronicity? Both of them you can take into solute load and also the solvent. So once you decide that this patient requires support, this particular paper also talks of what is the clinical scenario, what is the modality that you should start as a first option. But this also encourages to look at other options depending on your own setup and training of your staff as what should be the next option, and encourages you to consider to move away from a particular modality as the patient's hemodynamics, patient's milieu changes. So you can start somebody with a intermittent hemodialysis, patient does not do well, you can move to a SLED or a CRRT and vice versa. The particular patient, the politician we discussed, started off on CRRT, went on SLED, and then recovered and came off dialysis. So moving from one type of modality to another, based on the hemodynamic stability, intracranial pressure, the rate of fluid you need to remove, and the acidosis that is there, all these things make sense, what we now call as precision CRRT. So there was another ADQI immediately after this particular one, and the 17th ADQI talked of precision RRT in the ICU. 4 papers came out of it. All of them were published in blood purification. And this was the place. The venue was Asiago in Italy, a beautiful place. And these were the people. You can see John Kellam, Ronco, Mehta, Asita, and Marlies, all of them here. And they came out with 4 papers. I was in the group of solute control. So Bagsha was the leader for this particular paper, talking of, you look at a patient, you always start off with a default prescription for your dialysis. Let us say your dose is 20 ml per kg per minute. But your patient is not going to be the same for the next 7 days. The patient's hemodynamics will change, metabolic milieu will change, metabolic demands will change. So precision CRRT talks of a particular amount of default prescription to be started today, but every 24 hours to see the patient and change the prescription based on the patient's characteristics. So that brings us to the dose of RRT. We now know there is no need to achieve very high doses. At the same time, you cannot under-dialyze somebody. So most of us are comfortable somewhere between 20 to 25 ml per kg per hour as a dose on CRRT. Start it as default dose, and then on a day-to-day basis, you look at what happens in the patient, and then you can change the prescription. So the initial work on dose, Ronco thought 30-35 ml. Subsequently, ATN trial, Renal trial, all of them looked at a minimum dose is needed for good outcomes, but you don't need to reach very high clearances. But what you should keep in mind is what is your prescribed dose and what is your delivered dose. They may be a little different. So you have to have certain calculations once a day at least, like what we call as sieving coefficient also, so that you know your prescribed dose is so much, your delivered dose is so much, and most often there is a gap which you should meet or make sure the gap does not increase. So the other important thing for you and me, as you go to higher and higher doses, the antibiotics are certain life-saving drugs that you are giving. You may be clearing them in your effluent or dialysis. Keep that in mind and make sure that you know for every 10 liters of effluent volume, you have approximately 7 ml of GFR. Therefore, when you are dosing your antibiotics and other things, these things have to be kept in mind. So you have a loading dose, which will be the same as anybody else, but then subsequent doses, you have to make sure you know how much clearance that you are adding and how these antibiotics are handled, and you should supplement the dose accordingly. So moving gears, you may want to know there is a concept, not just dialysis, we know what is now called as renal support. So you may want to do a extracorporeal blood purification even when patient has normal renal functions. And this brings us to what is known as non-renal indications of RRT in the ICU. So this is one blood purification paper by Ronco's group, which talked of what is the rationale of using blood purification therapies in patients of sepsis and how we remove the pathogens, endotoxins, and then cytokine levels. It makes sense to use them in certain group of patients, and people have published good outcomes, including Indian data. So finally, coming to weaning from RRT, it is not an easy topic. You know, you will start it when patient's demand is more than capacity. When do we start weaning? There is not much literature on this topic, but as a concept, I would like to introduce every patient who is on dialysis, you should consider when should you wean this patient. Obviously, the urine output should increase, and there are some papers which guide us regarding when do we look at the urinary clearances. So one of the things that we now know is daily urinary urea excretion. That is, if somebody is making 400 or 500 ml of urine, you can do a timed collection of that urine and check in that urine for urea and creatinine. If there is a progressive increase in the excretion of urea and creatinine, it may be worthwhile giving a dialysis holiday and seeing whether the output further increases, and then patient may be on the recovery track. Otherwise, you may have to restart the dialysis. I will not be able to spend more time because of the paucity of time. But as a concept, we now went through what is the access, what is the modality, what is the dose. We are not spending any time on anticoagulation. And then we also talk about the weaning. So one or two things that we now know: every patient who is dehydrated, every patient who is fluid overloaded, you are causing kidney injury in the ICU. So it is important for us to spend some time with the patient and talk about how to assess volume status. Could be clinically, could be using certain modalities like the CVP or the IVC imaging. And these are extremely important because when you look at a AKI patient, the classical determination of pre-renal, intrinsic, and post-renal. Post-renal may be easy by doing just an ultrasound, but the other things are not that simple. And if you cause overload, patient gets into more AKI. If you cause under, that is volume, hypovolemia, you are worsening the acute kidney injury. Other thing that you should keep in mind is drug-induced element. We use so many drugs in the ICU, and all these can contribute to more injury and delay in the recovery. Certain drugs which are not nephrotoxic, like ACE inhibitors, diuretics, which are on board, you should consider whether they need to be withdrawn during this time. And then follow-up of AKI is given a lot of importance now. If you look at 100 hospital admissions, 20 of them develop AKI. Vast majority improve, even 2% would go on dialysis. The mortality goes up to 60% in AKI needing dialysis. When you follow up this group, 80% of those who need dialysis as AKI go into established CKD in the next 3 to 6 months. And then they die more often. 50% of them die in the next 1 year or so. 5 years later, if you look at, almost all of them will be on dialysis. So this type of follow-up is important because AKI means it is not recovery at the time of discharge from the ICU or hospital. Most of them have very poor outcomes, and this is a recent understanding, and we spent some time knowing why it is so. Therefore, follow-up is important. Every 3 months after a AKI episode, looking at serum creatinine or estimated GFR, and also urinary protein loss. That brings us to the concept of when patient is diagnosed as AKI, the first 7 days you are talking of acute kidney injury. Subsequently, up to 90 days, we call it as acute kidney disease. So you will look at these patients, look at their blood pressure, look at their urine protein loss, look at their estimated GFR, and then try to limit the damage further by various manipulations, including BP control, salt intake to be on the lesser side, and protein loss control. After 90 days, these patients enter into the spectrum of chronic kidney disease. So how do you follow up an AKI episode at the time of discharge? Depending on whether the patient had normal functions at the time of admission or was there a chronicity. So all these are clearly discussed in the 6 papers that I talked of from ADQI. So going to the renal support, which I just mentioned, you have to know different modalities that you and I showed you a patient on PD, similarly IHD, SCUF, SLED, and CRRT. All of them are complementary to each other. In a particular patient, a particular modality may be good on that day, but the same patient may go on another modality after a few days. We should be able to offer a good unit. We have the wherewithal to offer different modalities to different patients at particular time. So I was just mentioning to you about fluid accumulation, fluid overload. So when somebody has a fluid overload, your renal venous pressure also increases significantly, and you see the tubular pressure, which is high. So in the glomerular capillary loop, your tubular pressure high reduces the filtration pressure, and without any other reason, just fluid overload can cause acute kidney injury, and it can cause very poor outcomes to your patients. So you should know this is a clear cartoon wherein the filtration pressure in a normal person is 14 millimeters of mercury. When there is a fluid overload, intratubular pressure increases and the filtration pressure drops to 4 millimeters of mercury. So keeping this in mind, whenever you take a patient on dialysis, make sure you know how to assess the fluid status, and also your day-to-day assessment will help how much of volume to be removed without causing hypotensions, which will delay the recovery of AKI. So the basic tenet of continuous renal replacement therapy is to mimic kidney function, and every effluent volume, when you use something like 25 ml per kg per hour, you are able to give a good clearance. You don't have to go to higher amounts of doses. And you have to balance the fluid, solute, acidosis, electrolyte, look at the nutritional support and enhance the renal recovery. There is a lot of data talking of what you do in the ICU determines the renal recovery or establishes the CKD in your patients. So this is what I was talking of, renal replacement versus renal support. Renal support, you may want to support other organs like liver, lung and heart, whereas renal replacement, you are replacing the kidney function, and sometimes kidney may be normal and still you want to do the other modalities. So different indications for renal replacement, renal support are all discussed in these papers. So when you look at fluid management, you will have to have a little more knowledge of how do we keep a fluid prescription on a dialysis modality. It could be IHD or SLED or CRRT. I think Dr. Tapesh will allow us to have another session only talking of prescription of a patient, wherein what is net negative of fluid, what is keeping in positive balance, what is keeping in balance, all those things we have to discuss in detail. So a normal kidney not only removes fluid, but it also regulates fluid. Most of the other modalities only remove fluid. You cannot regulate. Whereas in CRRT, you are able to give and remove large volumes every hour, which will help us to regulate the fluid. One cohort of patients like intracranial pressure is high or hepatic encephalopathy. These are one cohort of patients wherein other modalities are known to have poor outcomes, whereas in a vast majority of patients, any modality used properly with enough understanding without causing hypotension will have good outcomes. The reason why the intracranial pressure or brain injury patients or hepatic encephalopathy patients do poorly in other modalities is the cerebral edema worsens, and this depends on the amount of fall in serum osmolality when you do a dialytic modality. Thank you. I think with these few concepts, I will stop there. Then we can discuss if there is anything. Thank you.
Thank you, Dr. Rajasekara. Excellent presentation. So I had a couple of questions, I think, just even for our audience, for them to kind of clarify the concepts. What I understand is that when you're talking, and currently at least, we look at the rise in the creatinine or a fall in the urine output as a marker of acute kidney injury. But in your particular ICU, are you looking at any of these biomarkers that can give us an idea about a early acute kidney injury besides the creatinine?
Okay, so we have data on NGAL in a cohort of patients who had coronary imaging, both angiograms by CT and conventional. Then we had around 108 patients we had done as a paper for post cardiac surgery, CABG. And then presently we are doing nephrocheck, that is urinary product of KIM and IGF in 10 sites in the country as a multicentric trial. So to answer that question in short, we are not using it on a day-to-day basis in daily patients, but we have roughly in 4 different time frames, we have used biomarkers and we have that data from the Indian subcontinent. There is some NGAL data from South India. Dr. Rajiv Anigiri's group, they have published it with good outcomes. So there is quite a few people in the country who have used it. Across the world, I am finding now more and more people who are able to use it. And my strong conviction is, though it is going to add cost, people are coming up with arguments. Even this cost is justified because the long-term ICU stay and the dialysis requirement, when that comes down, this justifies the cost. So we have to be familiar with these biomarkers with time, and that should be the standard of care. And I believe it will become part of the guidelines in the next couple of years.
Okay, excellent. Just coming to that case that you had brought up right in the beginning of your lecture, the gentleman who had this whatever gunshot and stab injuries and had gone into hemorrhagic shock, and then had developed acute kidney injury, and then finally when he was discharged also his creatinine was 1.7 and gone into nephrotic range of proteinuria. So do you see this commonly that patients who have a severe renal and then leading to renal injury, they can get a severe glomerular damage giving rise to a nephrotic syndrome?
So the particular cartoon I showed you about the AKI not recovering fully. So after 2006, there is more and more data talking about AKD. Once the 7-day time frame is over, we no longer call these patients as AKI. And AKD as a disease has two components. One is the drop in GFR, and second is onset of proteinuria. When you follow up these patients over a period of time, the parenchyma has areas of damage, fibrosis. So there is ischemic injury. So what happens is the remaining glomeruli, which are there normally, they hyperfiltrate. So one of the main mechanisms of acute kidney injury going into CKD is hyperfiltration injury, because you could have just lost 25% of your nephrons, but the remaining 75% are going to work 100%. So that is the reason why proteinuria becomes a major important marker for progression of kidney disease. So all the follow-up data, which I didn't have time to go into details, talks about reducing the proteinuria after an episode of AKI. And if you are able to do that, your progression of CKD comes down and your downstream effects after a few years also improves. So it is right what you mentioned. Not only the level of GFR, but the proteinuria is what determines the outcomes. And this is because the more the injury, the more the hyperfiltration, the more the proteinuria. Right. This particular patient left hospital at 1.7 with 3.3. His present protein loss is below 1 gram by whatever manipulations, but creatinine is now 2.2. So I believe every AKI patient, we were thinking at the time of discharge, yeah, this is fine, and we don't see him again or her again. But it is not true. Most of them need regular follow-up.
Right. Another question I had was that, that was interesting that you did this acute peritoneal dialysis. Are you able to, in somebody like the patient who is, say, having severe sepsis and multi-organ dysfunction is quite catabolic, is the acute peritoneal dialysis able to deal with the, clearance requirements?
So whatever data is available in literature, including from India, there is one study talking of randomization between CRRT and peritoneal dialysis. It looks like for vast majority of our patients, PD is fine. Myself and Dr. Emmanuel Birdman have written a paper on AKI PD in seminars in dialysis. We have summarized all the data and of course the advantages, disadvantages, also except in patients who have very high catabolic state. Majority of our patients should be able to get away with PD. And you may be, all of us are aware, in our government institutes, most of them do get PD and they improve. But somehow many of our ICUs, we are not comfortable for various reasons. I believe we should move towards PD, at least in a small cohort of patients. please look at the data from Brazil and from Indian subcontinent. The Brazil one was randomized again into two groups. This was by Daniela Ponce. She is the first author. And in the ADQI we conducted in Hyderabad, she was one of the faculty. So I have spoken to many of these people and they are able to do it. There is one author called Amarling. He has proposed what is known as a CFPD, continuous flow peritoneal dialysis. So what they do, instead of putting a single catheter, they put two catheters on the right and left hand side of the abdomen. They do, for hypercatabolic patients, continuous flow of dialysate from one catheter and it comes out from the other. And this is published data with a clearance rate close to CRRT, 25 ml per kg per hour to 30 ml per kg per hour. So I believe as a modality, it's extremely useful in certain patients and we all have to be aware of how to do it. This particular patient, I told you, we have some experience in acute PD, but I would be happier if you are able to do it more often. Yeah.
That's very nice because this is something that we also need to think about. My only concern was that, given these patients in the ICUs with these multiple lines and tubes, like you showed one of your patients who was also on ECMO and dialysis and ventilator and all the lines and tubes, etc. So when we are putting in these, PD catheters, in your experience, what is the increase in incidence of say, peritonitis that occurs or an infective peritonitis?
So peritonitis is not a major problem in acute PD because you are not continuing it for 7 days or 10 days. So most of the published data also talks of peritonitis as not a major problem.
Okay, that's good. And what about glycemic changes?
Glycemic changes are not an issue if the patient is not diabetic. If the patient is diabetic, either you titrate the insulin or you can add for every bag of PD, there is a particular amount of insulin that can be put into the bag itself. Into the bag itself.
Like we add to TPN, that kind of.
It's like neutralizing the.
You brought up something interesting about this proton pump inhibitors. In your experience, are you seeing them as a common cause of interstitial nephritis?
Yes. So even Indian data, there is a couple of publications of what is known as direct study, DIRI. This is drug-induced renal injury. This was a 21 centers across the world. In India, PGI Chandigarh and we, two of us were the sites. The total number of patients contributed by India was the highest in the entire study, more than 120 patients. The commonest was NSAID. Next was PPI. Third was quinolone.
Because I think most of our patients are put on PPI. So I think it's an important message for our attendees that we should keep in mind that these PPIs, besides increasing the chance of Clostridium difficile or aspiration, pneumonia, etc., can also predispose to interstitial nephritis and acute kidney injury.
So the knowledge of PPIs causing kidney disease came from large community data. So people found when they looked at CKD prevalence in a community, they tried to find out what was the reason. And then there was a direct correlation between those who had CKD and those who are on PPIs. So we did not know it causes AKI. Subsequently, now the present understanding is PPI directly cannot cause CKD. PPIs cause AKI by acute interstitial nephritis, which becomes chronic interstitial nephritis and causes CKD.
Right. So, because when we look at our nephrologists and they come and they give a prescription that avoid nephrotoxic agents, so they put in the aminoglycoside, but they often don't mention beta-lactams or the PPI, which themselves can also contribute to interstitial nephritis.
I believe when it is needed, we should use it, but we should not use it when it is not needed. 1, 2, we should not continue it forever, like many people are on it.
So with ranitidine or cimetidine, of course, that's the older one, you have not found these, and famotidine, you have not found the same kind of problem.
In fact, that becomes our drug of choice when we don't want to use PPI. Even in our OPD practice, The minute creatinine is a little high, we avoid PPIs and we use these drugs.
Excellent, because I am telling you, it's becoming such a reflex to prescribe a PPI in a patient who's critically ill because of the concern for any kind of stress gastritis. But I think we are not keeping in mind the possibility of interstitial nephritis.
Yes.
So Dr. Kothari sir, is that all, or you want to ask anything else, interact anything else?
No, I think just if any of our audience has any questions or something, that's also fine with us.
Okay, so sir, Dr. Chakravarthi sir, some questions for our audience, basic questions. What they encounter is, they're on call and on duty. So the patient gets admitted with something like a urea of 200, creatinine of 4. So how do you approach these patients and in terms of diagnosis and resuscitation? So this is a common scenario, the patient comes with urea 200, creatinine 4, gets admitted, our young people are there, and they have to kind of approach these patients, establish a diagnosis and resuscitate.
Okay. So I think you should always look at your patient as one, is there a pre-existing chronic element or not? If it is there, it makes your job a little easier in the sense this patient will not be able to recover beyond a point. The minute you have any of the indications, I did not go into those details of, I showed you one cartoon wherein when you say RRT, what are all the subtopics that you need to consider? The level of azotemia itself may not be an indication for dialysis, but when you take a level of azotemia like 200, then you don't want to hesitate, because uremia also contributes to organ dysfunction, encephalopathy, failure to tackle an infection, uremic cardiomyopathy. So you will want to start early. So when somebody has more than 150 or 200 urea, you will not hesitate. At the same time, please spend some time with the patient and see, is there very good urine output? If the output is good and azotemia is worsening, you may want to consider, is this patient going to get better if you give fluids? So the foolproof way of that is to look at the biomarker, which we do not have at this point in time. As I told you, if you have biomarker, you can categorize patients into 4 groups. When you do not have it, clinical examination, imaging, also we take the ratio of urea to creatinine. So if somebody has a pre-renal element, you get very high, disproportionately higher urea compared to creatinine. So this particular thing will tell you whether you can give more fluid and get away with it. Otherwise, for a level of that azotemia, I would want to dialyze early, especially if there is acidosis, potassium is on the higher side, or there is a fluid overload. Fluid overload is a very bad thing to have in a patient in the ICU. It has an independent risk factor for death, ventilation, number of days in the ICU, and also CKD. That means AKI becoming CKD. The reasons I already shared with you. So keeping that in mind, you just don't look at only the level of urea or creatinine.
Right. I think that was very relevant. I think the question also what Dr. Tapesh was the point you were trying to drive at was to distinguish between uremia and azotemia. Because I think many a times, I have my residents and my juniors telling me that, look, this is such and such is the number of the urea and creatinine and let us dialyze. But I think we also have to look at what is the physiologic impact of the same on the patient. If it's something which has been gradually building up, we have seen patients with creatinines of 18 and huge ureas who are otherwise looking very well. And in patients who have an acute kidney injury, a very relatively modest rise in the urea and creatinine can give rise to, as you mentioned, encephalopathy or fluid overload or severe acidosis, hyperkalemia, etc.
So, sir, next question, Dr. Chakravarthi, sir, would you like to talk about the pathophysiology in sepsis for AKI? Just summarize it, because it is distinct from ischemic ATN. It is commonly thought, erroneously, that it is probably the same as ischemic ATN, but I think the physiology differs a little. You can just briefly touch upon the physiology, the pathophysiology in sepsis and AKI.
Okay, so that is a relatively recent knowledge. We always thought when there is sepsis, there is hypotension. Therefore, there is a decreased perfusion to the organs. So one of the seminal experiments was a sheep where they injected endotoxin into the peritoneum, and then they could measure the renal blood flow individually in each kidney. They found actually in most septic cohorts or experiments, the renal blood flow is actually more. It is a hyperdynamic circulation. So you have, if somebody has a shock, then it is easy to explain the acute insult on the kidney. But vast majority of your septic patients who do not have shock still continue to have progressive renal dysfunction day to day. It is because of the shunting of blood from the capillaries. So the cytokines cause shunting of blood from arterioles to venules without going into the capillary circulation at all. For example, let us take the cartoon of fluid overload, what I showed you. The afferent arteriole and the efferent arteriole. The blood goes from afferent arteriole to capillary network and then goes to efferent arteriole. The filtration or GFR occurs in the capillary network in the glomerulus. In sepsis, there is a direct shunting of blood from afferent arteriole to efferent arteriole without the capillary, and this is true across the body. Every capillary bed is shunted, meaning the arteriole to the venule, the blood goes, because sepsis and the cytokine storm opens up certain channels causing shunting of blood. In other words, there is ischemia because the blood is not there in the capillary bed at all. This is one mechanism and a very common and almost universal mechanism in all septic milieu. Shock and underperfusion comes very, very late. The second mechanism that can happen is you have some amount of sludging, slowing of blood flow in the capillary loops. You actually have, people have demonstrated there is hypoxia to the tissue because one, capillary blood is not there. Two, whatever circulation is there in the capillary is very, very sluggish. They become slower. There is actually some amount of clotting because they have endothelial dysfunction in the capillary loops. And then some edema gets into the tissue. Your perfusion of oxygen from the red blood cell in the capillary to the tissue cell, the gap becomes more. So there are 3 or 4 mechanisms like this before the hypotension occurs and underperfusion occurs. So unless you reduce the inflammation and the cytokine storm by treating source control, starting your antibiotic early, and that is the reason I believe the dose of first antibiotic when the patient comes with sepsis is so important. It is not the hypotension. In fact, most often the injury is established before the hypotension has come in. Once hypotension has come in, it gets only sustained and worse. But all these 3 mechanisms of what I talked of, shunting of blood, slowing of circulation, hypoxia because in the tissue, there is an increased distance between the red blood cell and the tissue cell as the sepsis gets worse.
So I think what you're mentioning is that probably in the early sepsis, even though there may be a relatively normal blood pressure, the cytokines are actually causing dilatation of the efferent arterioles like ACE inhibitors and ARBs and reducing the filtration pressure across the glomerulus.
There is actual shunting. People have demonstrated that the blood does not enter the capillary flow, goes from afferent to efferent directly. Sepsis, cytokine storm opens up new channels. This is something like neocapillarization, pre-existing channels which get opened up.
So
and shunting of blood.
Okay, just in relation to the same thing, you showed this patient of yours who was on ECMO and also the dialysis, and there was also a cytokine filter. Okay, I just wanted to understand, because cytokines are such a confusing, kind of bunch of chemicals, whether they are inciting or are kind of ramping up the immune system versus inciting inflammatory injury. And here we are looking at trying to drag off these cytokines because we are concerned that there is progressive inflammation and damage because of the same. So with these cytokine filters, which cytokines do you kind of, in your opinion, are most important to be kind of removed from the system, removed from the body?
So we have some experience with polymyxin and relatively good outcomes, though the numbers are small. But during COVID time, there have been a significant increase in cytokine, that is cytosol, oxalis, and there is another filter called hemophil. So it depends on when you use it and what filter you use. But several people across the world have published that there are good outcomes when you use it. When I say good outcomes, we are talking of the shock getting reversed, number of vasopressors coming down, and of course, renal recovery over a period of time. I believe all over the world, the numbers are small, but people are now more and more comfortable offering it when other things fail. But too late may not help. And our own experience has been in the early stages when the shock is not getting better. You have taken care of volume status, mean arterial pressure is not maintaining more than 2 inotropes, you are entering to a third one. That may be a good time to use. I am happy to share our own data from the group. We have close to 100 patients during COVID time who were on these filters.
So just talking about the polymyxin filter, the surviving sepsis guidelines have been published just a few months ago, 3 months ago. They have written that we should not be using it as data suggests that it may actually be harmful. However, the Ronco, etc., and others have written that it should be used, and probably in the subset where you can measure the endotoxin levels. And I think they have given it as 0.6 to 0.9 units because that is what was seen in a study. I think it is Euphrates or Euphus study. So
Euphrates, abdomen, there were 2 or 3, but they were all quite small studies. You are going to see much more. As I told, all over the world, the numbers are not that big to put it as part of guideline. But if you look at the KDIGO paper, which you mentioned, I was part of 2019. The meeting was in Rome. There was a lot of debate because America does not use them. They are not approved in America. So it's not easy to include them. But if you look at the consensus statement, they have mentioned in one sentence and all of them agreed that it is something that should be utilized in a particular cohort of patients, is what they have written. I think it's a matter of time. As more data comes in, it is one of the modalities in sepsis. Mechanisms I briefly touched, that is from Ronco and Thomas Rimmel. Right now, Kellam is advocating it significantly. In fact, he's working with a company called Spectra, and they are doing polymyxin in a big way. But they advise, as you said, look at the endotoxin level and then use the filter. So
personal takes, sir, should we use it then?
So I can give you at least 26 patients, including 1 or 2 doctors, in whom polymyxin has brought down the number of vasopressors, reversed the shock and all that. And another 10 or 14 patients in whom it didn't help. So it is an option in a particular patient, depending on what is happening to that patient. If the patient is not getting better, it is definitely an option.
Would you look at interleukin 6 level?
Will you look at?
Interleukin 6 level?
So for polymyxin, we will look at endotoxin if it is available. But for the others which I mentioned, hemophil, the data suggests to use it only when there is a particular level of interleukin 6 or higher. But there are also some Indian authors who have found that there was no correlation between that. But the shock and the lung involvement improved.
Okay. Sir, can you just touch upon furosemide stress test?
So we discussed biomarkers. So one of the biomarker is supposed to be the urine output itself. If somebody gets a bolus dose of a diuretic, and makes good urine in the next 2 hours or so, it tells you that there is a fluid responsiveness. Actually, what it tells by mechanistically is the proximal tubule is intact. So when you give furosemide has to come to the site of action. It gets secreted and the proximal tubule goes down the tubule to the thick ascending limb of loop of Henle. So when you have a response to FST, and this was first described by Lakmir Chawla and group, and they found those who had a response to furosemide stress test did well when diuretics were on board, and it also means the tubule is functioning. So there are two things in FST. One is fluid responsiveness. If you can give more fluid and a diuretic, I'm not sure that makes sense when somebody is fluid overloaded. So by and large, you want to use a diuretic only when somebody is fluid positive. So you should be sure about it. Otherwise, using a diuretic is detrimental to the tubule and the kidney outcomes. There is actually mortality data talking of diuretic increasing mortality if somebody does not need a diuretic. But in a cohort of patients where you are not sure, you think there is fluid overload, giving a bolus dose of furosemide tells you that tubule is intact, and it will help you. That is also used as a biomarker.
So I had a question, like just as we use cooling in a patient who's had a cardiac arrest to try and protect the brain. If we look at furosemide and the loop diuretics and their effect on the 2-sodium chloride co-transporter in the ascending limb of the loop of Henle, is it so that if we give such a furosemide or loop diuretic, you would be actually reducing the energy requirements of the tubules?
Yes, looks like the energy ATP expenditure comes down a little, but the benefit is only in those who are fluid replete. If you give it in somebody who is fluid depleted, it causes more harm.
So can we use the FST as a guide for the RRT, sir? Because the outcome is the same whether you use FST to guide you to choose RRT or not.
So I believe if there is no compelling indication for dialysis, patient is fluid replete, trial of FST, and then the output is good, makes sense. In ICU, my problem has been fluid replete, but serum albumin low. So these people do not have the volume in the intravascular compartment. So by giving a diuretic, you are not going to cause more urine output. So you have to mobilize the fluid from extravascular compartment to intravascular compartment, only then the diuretic will work. So all these factors have to be taken into consideration.
So in your ICU,
Please.
In your ICU, what are the parameters that you use, and this is more for our audience, to tell that this patient is fluid replete?
So we do, apart from the clinical examination, I feel clinical examination is good, but apart from clinical examination, IVC is what we are looking at routinely. CVP, there is research in that in the literature, but my own experience has been it's not a great tool, both in surgical ICU and in the medical ICU. But we are looking at the IVC collapsibility. It seems to have a good correlation.
Just taking that forward, a very simple point. What about the role of pedal edema in assessing fluid status?
So especially if there are young people, if you are able to elicit even minimal pedal edema, that means the patient is already 3 liters positive. But please keep in mind whether that volume is inside the vascular compartment or not. Serum albumin measurement would have been done at least once. Have a look at it. And there are specific indications for giving a colloid. By and large, colloid itself for good outcomes is out, but there are specific indications for giving a colloid. And I believe one of them is when somebody has a low serum albumin and the volume is outside the vascular compartment, you don't want to dialyze unless you are sure this patient's tubule is not working. So these are one other cohort wherein you can either give albumin or you can give blood if the patient has a indication for blood transfusion. it is as good as giving a colloid. It will move your volume. The other thing is diuretic and a colloid. Lastly, dialysis, ultrafiltration and a colloid. So all this makes sense to move the volume into the vascular compartment.
So what would be your recommendation in using albumin, and what kind of albumin level would you consider giving albumin, and what kind of dosage?
Okay, so anybody with less than 3 in the ICU, clinically, we believe the volume is outside the vascular compartment. 3 days of 100 ml each we use. Wherever possible, we use low salt. Otherwise, we are using the regular one. And I believe in 3 days, it makes a huge difference. And whether you can decide whether this patient is going to require dialysis or not.
Then, what about the estimation of GFR in the ICU? What method would you advise? Because often, the drug dosing especially is very important. And what kind of a method? Should we use the Godfrey formula, or should we use, time urine collection? What is the best way to estimate GFR?
So, in the ICU, by and large, we look at the serum creatinine day to day. Today's creatinine, tomorrow's creatinine, keeping fully in mind that the creatinine you see today may not be exactly the renal function of today's. It could be 48 hours back or 24 hours back. We don't routinely do a estimated GFR bedside for various reasons. Creatinine serial, and we do sometimes do the urinary timed collection, especially when I am dialyzing a patient and the urine output starts. I want to stop it and decide whether it is just a urine or there is actually a clearance. And I believe it's a simple test. You can just collect for 6 hours today, 6 hours tomorrow, 6 hours day after tomorrow, or give a day gap and then collect it. You ask both for urea and creatinine in the urine. The reason is urinary urea, urinary creatinine. One overestimates the GFR, one underestimates the GFR. So use both of them, and it's just a simple test. You just tell your lab once or twice, subsequently they will be able to do it routinely. So I believe estimated GFR, like what we do either MDRD or CKDAP, day to day may not have a role. Serum creatinine increasing or decreasing definitely has a bearing, keeping in mind how much of fluid overload. We do use urinary timed clearance, both urea and creatinine clearance.
In your ICU, do you find any use for these markers like fractional excretion of sodium or urine osmolality or urine sodium, urine electrolytes?
So if you want to differentiate between ATN and pre-renal, theoretically, FENA should help, but practically, I have not found it useful, especially in the ICU. There is data in cirrhotics and certain special cohorts where it has had a definite role, but routine ICU work FENA may not be, because there is so much of interference and it's not a very reliable test in the ICU.
So what about urine sodium less than 20 and more than 40? Like a patient comes in fresh, not received fluids, not received Lasix, less than 20 has 100% sensitivity and specificity for.
If it is a virgin patient, it makes sense. The minute patient has got saline, the minute patient has got a diuretic, it does not make any sense.
Fresh patient, okay. So then finally, sir, just what biomarkers are we using now? Are we using any biomarkers? I think I missed that. You can just repeat. Are we able to use any of these NephroCheck and all commercially?
No, NGAL is available commercially in the country now. And NephroCheck we are using, I mentioned in 2 different scenarios. One we used post CABG, that was a thesis. And now we are doing across 10 centers a multi-centric study. And we have already completed close to 400 patients. So I believe we'll have some data shortly. Problem is the cost. These are not available in the.
So what is the estimated cost as of now?
Oh, initially they told us $100, which it won't work. But NGAL was available at 600 rupees per test.
So then finally, just the last couple of things before we take the questions from the audience. There are a couple of questions in the audience. So you mentioned that we can use increasing urea increasing urine urea values for stopping CRT. So what about the role of estimating the GFR and stopping CRT? Like it was said, at least, and it is said that the patient is improving clinically and the GFR is going beyond 20 ml, increasing, then you can consider stopping the CRT. So is that also okay?
Yes, as long as I mentioned, bedside, you are looking at a decreasing, let us say you are doing intermittent hemodialysis, pre-dialysis creatinine. If the last creatinine was 5, today's is 3 before dialysis, it means that there is some recovery of function. So you take into consideration dropping creatinine and the urine output both together. Other way to look at it is urinary clearance of urea and creatinine. So urinary creatinine overestimates GFR. Urinary, because there is some amount of secretion also. Urinary urea underestimates GFR because there is some reabsorption also. So when you take a ratio of these two, it becomes a very good marker of recovery of the tubule. And we have used it multiple times.
Well, creatinine is secreted, so it can overestimate.
It overestimates. So one overestimates and one underestimates.
Kothari sir, any other things you want to discuss, or should we take the questions from the audience?
So I just wanted to understand one thing in terms of NGAL. It is a enzyme related to neutrophils, right? So we are looking at inflammation, which is an injury causing inflammation causing the chemotaxis of neutrophils to the kidney, and then they're releasing this NGAL, which we are picking up.
Yes. So yeah, among the biomarkers, I told one is glomerular, tubular, then inflammatory marker. All this classification is based on the source of the biomarker. NGAL comes from a neutrophil. So there are two cohorts of patients where NGAL has no role. One is oncology patients, other one is sepsis patients. So in other types of AKI, and a lot of initial validation was done in cardiac surgery patients. It makes sense.
I think one of the other things is what they're saying about the biomarkers is, since it picks up early, you can have these nephrology care bundles, AKI care bundles, which can be instituted.
Yes.
Now it's going to be really helpful because you can actually prevent. You cannot really treat it once it's established. But since you pick it up within that 48 hours window period, you institute all your preventive care bundles. Avoid hypovolemia, avoid nephrotoxic drugs, and so on and so forth. So this.
Yeah. Tapesh, there are several authors now who have used it as part of their ICU care. And if you look at the data, it is very, very convincing. I believe it's just a matter of time. And I am privy to 2 or 3 ongoing studies also. Of course, Pravaki and all are already published. Big Pack study is already published. This Pravaki was in cardiac surgery, and the Big Pack was in non-cardiac surgery patients, but other surgeries. So they have used it as part of their ICU care. And you are right, even in the bundles, both European Society recommendations in the AKI bundle, and people have used these bundles and shown there are more than 7 studies wherein these bundles are used with biomarker and the outcomes are much better.
I think a lot of work is being carried on for this, and they're trying to even find out if you can get biomarkers which can predict dialysis also, whether the patient need dialysis, though so far there is no biomarker like that.
So I didn't have time to go through, but the same NGAL, people have used it to predict depending on the level. And there are some new ones called CCL4, one biomarker, and there is one more called enkephalin, pre-enkephalin. So they are all very robust biomarkers. Even the NephroCheck was, out of 300 biomarkers, it was its performance was the best. So I believe we are having now the wherewithal to predict AKI, pick up risk, people at risk, and also when you use them as a bundle, prevent downstream effects. In all of them, predict dialysis requirement when they are beyond a threshold value. So biomarker, the problem is you can have a increase and then it can come down. Unless it's a sustained biomarker, it does not help in your prediction. So you have to have serial values. That's what I was trying to get at. And I think it's a whole topic by itself. Yeah.
Okay.
I think from bedside to molecular, that's how we have moved.
Okay, sir, some couple of questions, sir. So, in case of peritonitis related to PD, does it be required to change the PD catheter every time, or antibiotics is enough?
So peritonitis in a chronic PD patient is totally a different ballgame compared to acute PD. In acute PD, you will do cultures and you will give antibiotic. Look at the cell count. If it is coming down, you keep, otherwise you have to remove the catheter. In chronic PD, the guidelines are little different, the organisms are different. So I believe, I hope the person is clear whether he is asking about acute or chronic.
I think it should be taken as only because
Asking about acute.
yeah.
If it is acute, the peritonitis is not that common unless we don't do a good job of handling it. And we are not nowadays putting stick PD, that is the rigid catheters. We are putting the tank off and leaving it till the patient recovers. There is a large experience of this in pediatric patients who needed acute PD. There are hardly any peritonitis. The tank off PD catheter, when you put it, it is not like a stick PD. Stick PD goes directly in, there is no cuff. Whereas tank off has a cuff and it does not allow infection to get in. Yeah.
The second question is related to what you said, sir. What kind of organisms should we expect? Is it okay to cover only gram-negative, or we need cover for staph and other gram-positive?
So to a large extent, it depends on your own institution. If you look at the Western data, they talk a lot about gram-positive, but most of us see only gram-negative. I believe, and what we used to do, including Dr. Mani's time, we had to look at our last 1 year cultures and take that as the empirical. Our antibiotic policy always looked at either last 1 or 2 years cultures and then looked at the empirical antibiotic.
And otherwise, also, sir, overall staph is much less in India as compared to the West overall.
Yes, yes.
Yeah, mainly gram-negative. So the final question is, sir, for acute liver failure patients awaiting transplant, RRT is indicated, high flux RRT. So for this, I is better than SLED question. So I think you already covered that, but maybe you can
Yes. In fact,
target ammonia level.
See, ammonia comes out with any filter, any type of dialysis, ammonia comes down. You don't need any special filter for ammonia. Regular hemodialysis filter also, ammonia comes down. But because liver failure is associated with some amount of encephalopathy, it is always better not to allow fall in the serum osmolality. Thereby, you would want to use a continuous therapy rather than a short intermittent hemodialysis.
So I think that was about all as far as the questions are concerned. So Dr. Kothari, sir, you like to make some concluding remarks before we ask Dr. Chakravarthi sir to conclude?
So I think it was an excellent presentation by Dr. Chakravarthi, and thank you, Dr. Vatsal, for organizing this. I think a couple of take-home messages, even in reference to the case that Dr. Chakravarthi presented, it's very important to be able to understand what is the fluid balance of the patient, especially a patient who's critically ill, and to make sure that we are having a bedside assessment, also maybe using the ultrasound for the IVC or some dynamic measures like straight leg raising, etc., or the head, the bed tilt test to make sure that you are not having an underfilled circulation, which can predispose to greater renal injury. Also, at the same time, it's very important to understand that there are certain drugs that we are using very commonly in the ICUs without really paying attention to the fact that they can be contributing to the renal injury, out of which, of course, the proton pump inhibitors are something that, all of us need to take home as a, important message, that use them only when it's clinically indicated, otherwise not to use them left, right, and center as we are doing at present. And thirdly, I think that this concept that now we are looking at a molecular way to kind of pick up early kidney injury, and looking at these, looking at the whatever different physiologic reactions which are going on in the body, and the neutrophils releasing certain enzymes or certain other markers of the micromolecules, are basically going to be adding to the ability to understand that there is a kidney injury here even before the creatinine starts to go up. Because as Dr. Rajasekara mentioned, that if the GFR is going to drop from 140 per minute to 70 ml, that's when the creatinine moves from 1 to 2. And also looking at the fact that the urea, and one side looking at urinary urea would be underestimating the GFR because it is reabsorbed, whereas the creatinine is overestimating because it's secreted. So I think, just not taking the GFR as a marker of the patient's kidney function, but also looking at some of these molecules and some of these biomarkers is going to increase our ability to pick up early kidney injury and thereby increase our vigilance to make sure that we are maintaining an optimal volume. Because as Dr. Rajasekara mentioned, that if you're going to have a fluid overload, one thing is not only are you going to increase the amount of hydrostatic pressure within the Bowman's capsule, which may itself interfere with the glomerular filtration, but at the same time, you're going to increase a diffusion barrier between the capillary and the tissues, and you would have a sort of a tissue hypoxia because of the same. So I think the optimal fluid management is what is very important.
So thank you, sir. Thank you for your valuable inputs.
Thank you.
Your concluding remarks before we conclude the session.
Oh, no remarks from my side. Whatever Dr. Kothari said, I think.
Okay. So thank you, sir. Thank you, Dr. Chakravarthi, sir. Thank you, Kothari, sir. And I thank you for their patient hearing, and thanks CIPLA for providing the digital platform. So the next webinar will be on 27th of March. The topic is nutrition in the ICU. So thank you, everybody.
All right. Thank you so much.
Thank you.